Here we have a CTPA on 50-year-old with history of shortness of breath and history of recent long travel. We need to visualize the CTPA in angio or CTPA windows, not in the mediastinal or soft tissue windows. So what we see here is unremarkable main pulmonary artery, unremarkable right and left pulmonary arteries. And as we come down, we start seeing the lobar arteries. And as we come lower down, the lobar branches are dividing into segmental branches. And as I come lower down, what we see here is at the level of branching of the segmental arteries, there is definitely a filling defect. And similarly, on the left side, we have got left descending pulmonary artery or the left lower lobar artery. And as we trace it lower down, as I come down, there is definite filling defect or non-opacification of the contrast for very, very long segment. So these features are consistent with the acute pulmonary thromboembolism involving the segmental and subsegmental branches of both lower lobes. This is very important to note adequate contrast opacification in the pulmonary arteries to visualize segmental and especially subsegmental branches. It is important to comment the contrast opacification of the main pulmonary artery. If it is suboptimal, we need to make a comment because segmental and subsegmental PE cannot be adequately evaluated with suboptimal contrast in the main pulmonary artery. In summary, here is a case of isolated segmental and subsegmental pulmonary thromboembolism in both lower lobes. And I've shown here for the residents how to look for these small or subtle but not so infrequent pulmonary thromboembolism.